This is a 2019 re-recording of the first in a series of 3 webinars, originally produced in August 2013 under the California Race to the Top Early Learning Challenge Grant. Virginia Reynolds, Program Director of the WestEd Center for Prevention and Early Intervention, welcomed participants on behalf of the California Department of Education Child Development Division and other participating state agencies. She explained that the webinars will address the 3 R's that form the social and emotional foundation of learning: relationships, resilience, and readiness. The lead presenter for the webinar was Dr. Karen Finello, an applied developmental psychologist with a specialization in infants and young children from birth to age 5 and their families. Dr. Finello received her doctorate in psychology from the University of Southern California and has been an associate professor in pediatrics and psychology at USC and professor of clinical psychology at California School of Professional Psychology, Los Angeles. She is currently a project director at the WestEd Center for Prevention and Early Intervention and continues as an associate professor in the Emeriti Center at USC. Dr. Finello has developed, directed, and evaluated home visiting programs since 1983, focusing on very young children with behavioral and health issues, infants and toddlers with significant healthcare needs, and families of infants and toddlers dealing with threatening conditions and terminal illnesses in their children. She has extensive clinical and research expertise in early intervention, infant and preschool behavior, assessment, cultural components of child rearing, poverty issues, home visiting, and the development of high-risk infants, toddlers, and preschoolers. Dr. Finello has provided consultation to school districts, hospitals, and community, state, national, and international organizations in the areas of infant mental health, early childhood development, reflective supervision, and program development. Dr. Heffron also presented this webinar with Dr. Finello. This re-recording does not include the voices of the original presenters. However, the content remains the same as in the original webinar. Welcome to the first of our 3 R's webinars. We are delighted to share our passion for infant, family, and early childhood work with all of you. The 3 R's material was developed to promote an understanding of the very important underpinnings of early childhood social-emotional well-being and school readiness. The 3 R's of early childhood are relationships, resilience, and readiness. This webinar will focus on the period from birth to 18 months and the critical role that relationships play in development. When considering the development and maintenance of healthy infants, toddlers, preschoolers, and parent relationships, it's important to recognize areas of vulnerability and of resilience. This allows us to consider not just the risk factors, but all of the resilience factors that families hold. Early social and emotional development is integral to all development, but is often ignored. This is significant, considering how all development is interwoven. Thus, young children cannot be separated into small pieces to examine individual aspects of development. Instead, we need to look holistically and think about how the development of social and emotional well-being in children under 5 includes child behavior and health, family functioning and social relationships, and caregiver-child relationships. This includes early brain development, preschool relationships with peers, and parent-child relationship issues, including attachment and goodness of fit. Throughout this webinar, I will use the words caregiver and mother interchangeably to indicate our focus on the primary caregiver, which in most cases is the mother, but not always. So when we use the term mother, this could mean grandmother, father, or whoever is the primary caregiver. The earliest period of infancy lays the foundation for all future development. So in the 3 R's, we talk about how, from an early age, babies learn about trust, and then how to rely on others. They begin to understand, you're there when I need you. Another thing that babies learn early is emotional expression. And we want to see a full range of expression in our young children, in all children. Early on, babies learn how to express their needs and begin to understand that their needs will be met. Early infancy also lays the foundation for the very beginning of regulation and regulatory behavior, which we know is a crucial readiness factor. In the beginning, regulation shows itself in the development of self-soothing and calming behaviors. Infants learn what to expect from the world in terms of regulating themselves and responding to the calming influence of the caregiver. So the mothers or primary caregivers play a really critical role in helping babies learn to calm, as they are the models for calming behavior. The challenges we face include the need to move quickly because we know that babies can't wait. This is a period of rapid development, and we don't want to miss opportunities to promote healthy development. It is critical to work toward the goal of good enough parenting. And as professionals, we must understand the developmental functioning of every family member. We know that relationships are the key to change, and the development of relationships is the key to all other areas of development. These critical areas include the ability to initiate, discover, and learn, the development of persistence and attention, the development of coping mechanisms, the development of self-regulation, and the development of emotional range. Many factors can affect social and emotional development, including developmental delays in the baby, serious health issues with the baby, or an environment with multiple risk factors. For example, poverty, substance abuse, adult mental health issues, or domestic violence. All development requires external support as children develop their own internal capacities. A developmentally based approach focuses on the developmental characteristics of both child and caregiver, attachment and its behavioral manifestation, neurobehavioral status, temperament, and the caregiving environment, past and present circumstances, resilience, health risk and/or disorder, protecting and predisposing environments, and the social and cultural expectations of the community. In addition, there are significant factors that we know impact early development, including biological and constitutional factors, prenatal factors, infant-caregiver relationships, caregiver influences, experiential influences, and community influences. The brain behavior relationships chart is intended to show you at a glance the complexity of these pathways to healthy social and emotional development. So look at infant mental health in the center of the chart, which includes healthy attachment and emotional and behavioral relations. Imagine how all of these other factors play into each other and interact with each other. As you can guess, maternal availability leads to healthy mother-child interactions, and that leads to healthy infant mental health. Maternal availability hinges on things like how a mother internalizes maternal representations and what kinds of supports she has, along with positive maternal mental health and spiritual and economic well-being. Let's take a look at what babies bring to a relationship. With babies, we're thinking about things like temperament and/or social style. We're thinking about how they express their emotions. So you may have the baby who is pulled back and quiet, or the baby who's giggly and gurgly and just initiates and engages a lot with the world around them. Babies show emotional expression in different ways, and they get responses from the world as a consequence of how they engage. Their physical health status will impact behavior. So a baby who's constantly sick is going to bring something different to a relationship and may require a lot more of a relationship in terms of engagement and interaction. The Harvard Center on the Developing Child website has some wonderful material in terms of what we need to think about with early childhood. One of the really important things to think about is the neural connections that are made. There are 700 new neural connections formed every single second in the first years of life. So if you look at the neural connections in a newborn compared to 6 months later, and then 2 years later, you can see the complexity and how rapidly these neural connections unfold. The early years really matter because those connections are formed through the interaction of both genes and the baby's environment and experiences. especially serve and return interactions with adults, or what developmental researchers call contingent reciprocity. As an example, the adult does something and the baby responds, and then the baby does something and the adult responds. That's the whole notion of serve and return. These are the connections that build brain architecture, the foundation upon which all later learning, behavior, and health depend. The work in brain science has really helped us to promote an understanding of the importance of early relationships and early development. So when you think about development and neural connections, if you look at the types of neural connections used for different functions, they develop sequentially. If you look at the first year of life, neural connections important to sensory pathways peak during that period. So the vision and hearing connections peak early in the first year, and then development of those neural connections kind of taper off. Language is really showing an important growth in neural connections later in the first year of life, with neural connection development dropping off during the 2- and 3-year-old period. Neural connections required for higher cognitive functions peak in the period between 1 and 2, and then begin to taper off. So we see how critical the early childhood period is for school readiness. Keep in mind that there are significant disparities that appear very early in terms of things like vocabulary. If you look at 18-month-old children, the difference in vocabulary among children of college-educated, working, and welfare parents starts to shoot up after 18 months. By 3 years of age, the vocabulary of young kids of college-educated parents is significantly higher, at least 2 to 3 times larger than those whose parents had not completed high school. So it's really important to think about early experiences and the environments in which children develop and how this has a lasting effect on later successful school performance and life success. Barriers to children's educational achievement start early and continue to grow without intervention. It is really important to get things right the first time because it's much easier and more effective to intervene with children who are very young than when they are older. Early childhood matters because experiences early in life can have a lasting impact on later learning, behavior, and health. In considering a developmental transactional model, we realize that there is a complexity of factors across developmental areas, and over time, that interact with the social cultural context to explain child functioning at any given moment. And so we think as developmentalists about the notion of cumulative adversity. The greater the number of risk factors, the greater the variation in outcome, as documented by Arnie Samaroff in the 1980s. We also know that there is a compensating force of opportunity that is crucial in compensating for adversity and risks. What do we consider among the risks to relationships early on? First of all, we think about separation and loss. Separation and loss can occur on a lot of levels. We can see separation and loss through things like death of a primary caregiver, or through things like repeat hospitalizations of either the baby or the primary caregiver. Another risk is multiple caregivers. And by multiple caregivers, we don't mean a primary caregiver, for example, the mom and the dad and the grandmother and the childcare worker or the nanny. Instead, we consider serial primary caregivers as a major risk factor. This can occur through foster placements, when an infant is moved from one foster placement to the next, leaving him at risk in terms of relationship development. Instability is another risk to relationships, and mental stressors are a risk because they stress both the caregivers and the extended family, whoever is in the environment of the baby, because then there's no buffering. The more stressed the adults are in the baby's world, the less they are able to buffer the stress for the baby. Substance abuse in the primary caregiver, domestic or community violence, and inadequate support for the primary caregiver are all important risks to relationships with the baby. So we really need to think about what supports the parent or caregiver may have in dealing with the complex issues in their lives. Think for a minute about mothers bringing their babies home from neonatal intensive care units, where they were being treated for multiple issues associated with being born too early and too small. Caring for these babies requires so much physically of these moms 24/7 that you wonder how they're even able to do it. and the risk goes up exponentially when there are additional risk factors in the child and family's lives. Maternal risks and influences would include things like, what are the mom's wishes and hopes for this baby? Some research studies have examined maternal beliefs prenatally with pregnant women, including what their hopes and their dreams are about their baby. Such beliefs can have a great influence upon development and relationships because they form a set of expectations that the mother holds. In addition, present circumstance in which the mother lives are very important. The mother who is in really poor health and who's really fragile in terms of mental health is critical to consider. For example, a mom who has cancer and has been diagnosed as having 6 months to live and just delivered a baby may exhibit very different behaviors than a healthy, robust young mom. These behaviors will influence the relationship with the baby differently. The mental health of a mother is really important to think about. Mothers who are severely depressed or moms who are schizophrenic have much higher risks in terms of relationship development. Knowledge about development, families, and child rearing are important. The mom's judgment is also important. We tend to think oftentimes that a lot of this is just basic common sense, but many people, frankly, don't have good judgment and common sense. So we need to help support good judgment and common sense and help new mothers understand the importance of the behaviors they exhibit with their babies. Sometimes their past history has led them to formulate a specific kind of belief system because their beliefs reflect how they've been reared and what they've experienced. Finally, a woman's coping mechanisms and resilience, or ability to bounce back from adversity, are important factors to examine when looking at maternal influences on a baby's development. So we need to think about the whole notion of family vulnerability. What were the mom's past experiences as a mother? Did she have other children that were removed by Child Protective Services, so she never had the experience of being a mother? This is her 4th delivery, this is her 4th baby, but she's never been a mom because all of her children were removed from her care right after their births because of her substance abuse. Now she's gone into treatment, she has custody of this child, so this is her first time experience as a mom, even though she's had multiple live births and has other existing living children. Next, what's her own personal history of child rearing? We think about moms who themselves were reared in multiple foster homes and never really had a primary attachment, never had anyone who considered them important, never celebrated a birthday, never celebrated important events in their lives because there was no one there for them. So they don't know how to do it for their children. What's the mom's psychological state? Is she mentally healthy? Does she have other issues going on? What about her physical health and well-being? And then we think a bit about the ghosts and the angels in the nursery that act either positively or negatively as she remembers and re-experiences her own personal history when she engages with her infant. These ghosts refer to factors such as the history of child rearing experiences, her past experiences with professionals, and her experiences as a mother. In terms of additional challenges, we must consider the physical health of the baby, ongoing or sudden family crises, and cognitive or neurological problems in either the infant or the caregiver. So it's not just the baby's problems that we think about, it's also issues going on with the mom. A really important thing to consider is, what do risk factors really mean? Having a risk factor does not mean that the child is at immediate risk for poor outcomes or needs intervention services. That's not what we're trying to say, and it's a concern that families have when we do risk assessments. I've heard from a lot of families who are really put off by a risk questionnaire. They feel like it's labeling them as bad parents. We're looking at individual risk factors that may mount up and create a need for extra support. That's the message we should be conveying to families when we ask about risk factors. Many times, the family can provide the buffering themselves, but sometimes they need a little bit of support in order to create that buffer. But research has shown that there is a far greater chance of delay in young children with 7 or more risk factors. We know that significant adversity impairs development in the first 3 years of life, and the more adversity a child faces, the greater the odds of a developmental delay. Indeed, risk factors such as poverty, maternal mental illness, child maltreatment, single-parent households, and low maternal education have a cumulative impact. In a study by Barth and colleagues in 2008, maltreated children exposed to as many as 6 additional risk factors were found to have a 90 to 100% likelihood of having one or more delays in their cognitive, language, or emotional development. How do we think early experiences get into the body? Work by the Harvard Center on the Developing Child indicates that the first way is through the embedding of disruptions caused by adverse experiences during sensitive periods in the development of the brain or other organ systems. As an example, there are lifelong cognitive and physical impairments associated with significant prenatal alcohol exposure. This is considered a time-sensitive effect. The second way experiences get into the body is from cumulative damage or biological wear and tear caused by recurring experiences such as abuse, chronic neglect, or exposure to violence, especially when this is added to the everyday stresses of family economic hardship. The biological mechanism for this weathering effect is related to the adverse impacts of the chronic activation of the body's stress response systems. Stable relationships with supportive adults that help young children learn how to cope with stressful circumstances can make the difference between positive adaptation that promotes healthy development and negative disruptions that can undermine the architecture of the developing brain and other biological systems. The website at the Harvard Center on the Developing Child has comprehensive materials, graphs, charts, and short videos that describe all of this. I recommend the website highly. Now let's look at the family and caregiver factors that are protective in nature. These include parents with personal histories of secure attachment, families who are able to get support in times of stress, a household that has rules and structure, the support and involvement of an extended family, although it is important to consider that just having an extended family nearby may not always be a protective factor. Sometimes the extended family creates conflict and additional risk. Other protective factors include a stable relationship between the child's parents, parents who model competence and good coping strategies, and family or neighborhood expectations of pro-social behavior. The next area we want to think about is attachment and all of the complexities associated with that word and its use. First of all, what is the difference between bonding and attachment? People use these terms interchangeably, and they're not really interchangeable terms. Bonding basically refers to the love and caring relationship that a mother develops with the baby immediately after birth. So moms will talk about how they bonded as soon as the baby was born and they held them. They held their baby and they were just enchanted by that baby and bonded. Bonding is a unidirectional concept. It is from the mother to the baby. Attachment, on the other hand, is a reciprocally affectionate relationship between mother and baby. That's bidirectional, with attachment occurring between both of them. According to Bowlby, the pioneer in attachment studies, what is important is the security of attachments. What does attachment look like? And again, we're not going to go into the Ainsworth style of measuring attachment in laboratory settings. Ainsworth developed the strange situation as a laboratory measure for developmentalists to look at the type of attachment between a young child and the mother as part of formal research protocols. She laid out different categories of attachment, but we're not going to look at all of those or talk about those today. We're going to focus instead on the key features of the relationship that lead to solid, secure attachments, and the role of early attachments in laying patterns for all future relationships, including later peer socialization and adult relationships. We know that early attachment between mom and baby creates the basis for all future attachments and relationships. So the relationships between herself, her partner, her boyfriend, when they're in their teens, 20s, 30s, 40s, and beyond. All of those relationships hinge on the development of early attachment, and this is why early childhood is so important. Now, there are special issues that do impact relationships and attachment. These factors include things like lengthy or repeat hospitalizations during the first 2 years of life. So for example, a baby who's a very small preemie, born at a very low birth weight at 24 weeks gestation, who spent 3 months in the neonatal intensive care unit, was discharged in the winter months and has been constantly sick and rehospitalized many times, is at risk for attachment issues. The relationship between mom and baby is threatened by the physical health and isolation of the baby in the hospital, and that threatens the early development of attachment. It makes it much, much harder for that family to engage and to work on attachment because the baby is in the hospital and the mother and father are at home with other children. They visit, but are not living with the baby. Then there is this huge risk of life-threatening special healthcare issues. Some of our early intervention or small preemie follow-up programs work with families who have been told at the time of the baby's birth that their baby has a maximum of 3 months to live. The family may be reluctant to give too much or attach too much because the pain will be so enormous when the baby dies in a short time. So they may pull back, and it is important for early interventionists to go into the home to work with families around such issues, to help clarify medical information and ensure that the family develops support and becomes comfortable in developing a relationship with this fragile baby. Prematurity and neurologic problems in the baby can impact relationships because when you have a baby who is different and turns away and can't look at you for very long, this leads many moms to think, it's my fault that my baby won't look at me. I must be doing something wrong. And the moms may give up rather than keep trying to engage the baby or to give the baby the time needed to engage. Separations impacting attachment and relationships may also be due to parental or caregiver hospitalizations or deaths. As an example, if a grandmother is caring for the baby and the grandmother dies, there's a lot of grieving in both the parent and the baby, and this can impact early relationships. And finally, multiple foster placements put young children at really high risk in terms of relationship and attachment. Maternal behaviors predicting secure attachment include things like sensitivity versus insensitivity in the mother. So a mom who is insensitive in terms of her behavior with the baby is going to have a different kind of attachment. Acceptance of the baby versus rejection is another important characteristic of behavior. Accessibility is another. A mom who is accessible, as opposed to one who ignores her baby or is neglectful toward her baby, is going to impact the development of the attachment and the type of attachment that's developed. And cooperation versus interference. So those of you who watch and observe moms and babies and perhaps have done assessment with moms and babies know there can be a caregiver that's constantly interfering and doesn't let the baby do anything. They're constantly doing it for them or interfering, moving the toy out of the way instead of encouraging development and cooperating in the development of that baby. These first 4 categories were used by Mary Ainsworth when she developed the strain situation. In the early research, each one of those was scored on a scale of 1 to 9, with 1 being least positive and 9 being most positive. And then these other factors were added, including comforting the child when the child needs comforting, and being able to accept the child's range of feelings. We also want to think about additional factors, including sensitivity and responsiveness to the child's cues. Like when the baby starts to rub their eyes and turn away, the cue is, okay, I need a little bit of away time. I need you to quit engaging with me. The mom who responds to these cues is going to help to develop a more secure kind of attachment with the baby. It's important to avoid being too intrusive or too directive, so to not overwhelm the child. Sometimes, for example, we work with very young teen moms who are very inexperienced, because these days many girls don't babysit like they did 20 to 40 years ago, and girls don't come from big families where they had lots of interactions with babies. Sometimes the first interaction you have with a baby is when your baby is born. So it's important to learn how to not be intrusive or too directive. You tell a teen mom, for example, play with the baby, and they dangle the toy and then pull the toy away. And they're directing the play instead of helping the baby learn how to play and modulating that play. So we're looking for these types of features of maternal behaviors that are important to help support mom or model when working in the home, especially with moms and babies. Showing positive feelings is important. Moms that can show positive feelings show secure attachment and show genuine love and joy. Moms who are severely depressed and have a hard time with this may impact the child's attachment development. It's also critical to allow the child to be separate and autonomous while still keeping them safe. Parents are supposed to maintain the safety of their child and the environment while allowing them to grow. So if the baby is learning to walk, you want to make sure the corners of tables are covered so they don't crash and hurt their heads. but you also want to allow them to learn to walk and move around the room. So you create a safe environment in order to make this happen. Then what creates change in attachment? Can we change attachment behavior or the attachment style? In both positive and negative ways, attachment may change. We have many negative caregiver life experiences that will impact how they respond to babies, and then that bidirectional influence is altered. So a caregiver experiences a death or the caregiver dies. For example, what if the father dies and mom goes on grieving for the loss of the baby's father? She pulls back emotionally, and the attachment and the relationship may be altered. It may impact attachment. With lengthy unemployment, what happens is that people become depressed because they're unemployed, and they get flat and attachment changes. This may impact attachment. Positive life experiences could be with a partner. It could be with a family member who moved and joined the family from Guatemala, and now they're in the home and helping be supportive. It can sometimes be the types of services they're receiving. A home visitor can be the one who is helping build that new supportive relationship, stabilizing the learning conditions. It can be one positive experience that will promote and lead to a positive change and an improvement in attachment. Successful interventions, we also know, are really, really important in creating changes in attachments and positive attachments. So is attachment only about mothers? We know that babies develop attachment with more than one important caregiver. And one of the fears you often hear with new moms, and I have especially heard this with professional moms, is when they go back to work, they're so terrified that the baby's going to attach to a childcare worker or a nanny because they're spending the day with them. Well, that typically doesn't happen, but what we want to see is multiple attachments. Attachments are not all of the same quality. We know there is typically what we call an attachment hierarchy. And in attachment hierarchy, we know that babies and toddlers show a preference when they're distressed to their caregivers with the most sensitive responses and with whom they spend the most time and feel the most secure. Usually it's mom. When you watch, they're perfectly fine with grandma or whoever is providing childcare most of the time and happy and are attached to that additional caregiver. But when they're sick or distressed, they want mom, their primary caregiver. They want to be held by mom, they want mom there. There are also mixed attachments, and by mixed attachments we mean with one caregiver. So for example, with dad, there's a secure attachment, but with another caregiver, it's an insecure attachment. Babies do better, we know, if the secure attachment is with the mother than if it's with someone else. It's what the research has indicated over time. The most important attachment is with the mom. It's better if the attachment with mom is secure. The important point about attachments is that attachments may be different with different adults. So you typically have a primary attachment with one person. If the child seems constantly sad or withdrawn or aggressive or out of control or gloms onto whoever walks in and seems to be attaching to somebody they don't even know, like a complete stranger in the park, we will then want to think about referrals. We'll want to work with a family to get them into mental health treatment or to be assessed if we're seeing issues that we're concerned about, because all of us are not experts on evaluating attachment, nor do we think everyone should be. If you are seeing indicators that are giving you the gut feeling that something's wrong, that the family needs more than what I can do, you want to refer. Another concept to consider regarding relationships is emotional availability. Emotional availability is defined by Bob MD as a mother's readiness to accept and reinforce a wide range of positive and negative emotional expressions that enhance mutual empathy and promote the child's sense of positive self-perception. So the ability to reinforce all of this range of behaviors and range of expression is critical. We're going back to the earlier notion when we talked about promoting that range of emotions. It's not that every baby should be happy, happy, happy. There are sad times, and babies do get distressed and upset, and you might be able to support that, as well as the happy, joyful, giggly time too. Emotional availability is really a critical factor in parent-child interaction, and it's really about the quality of the emotional exchange. Again, this is not unidirectional, this is bidirectional. We're looking at the accessibility of the parent to the child and the child to the parent, and the ability of each to understand the other through communication and to respond appropriately. It's important to think about reciprocity here because it can impact emotional availability of that baby to the primary caregiver. It impacts the overall ranking of emotional availability. Such factors like caregiver sensitivity, the way the caregiver structures the environment, non-intrusiveness, non-hostility are all important. These factors are the same measures that we look at in terms of positive attachments and promoting secure attachments. Emotional availability is the key component of attachment. And emotional availability is considered to be a really good global index of the overall quality of the parent-child affective relationship. So there are lots of programs that use the Beringen Emotional Availability Scale because it's a nice, easy way to look at this affective relationship. The Emotional Availability Scale includes 4 factors related to mom: maternal sensitivity, maternal non-intrusiveness, maternal non-hostility, and maternal restructuring. Then there are a couple of factors related to the child, like child responsiveness and involvement with the caregiver. Each of these are ranked on the emotional availability scale in terms of being either optimally sensitive or highly insensitive, or being optimally structuring or how intrusive the mom is being. In terms of how the child is, are they highly involved with the caregiver? Is there an optimal level of involvement of the child with the caregiver? So it's really important to think about the fact that emotional availability is not just about the caregiver, but it's about babies too. This baby, for example, would turn away and be jittery and didn't want to be held. This could give the mom a totally different sense of what is typical about her ability to interact with this baby, to stay engaged, and to remain emotionally available. There are times that moms can feel like they're just pulling away themselves, and they shut down. It's important to understand what babies bring to the equation and consider that when developing interventions and working with families. It's also really crucial to think about the fact that nurturing and availability require inner resources. It's hard to nurture when you're empty yourself. One of the things we found in a number of studies that we've done with babies and moms in the Los Angeles area is that the hardest thing to impact is the nurturing skills on parenting scales. Because nurturance requires so many other kinds of resources, both external and internal. You can impact how families set up discipline and how they set up expectations and what they think of development. It's really hard to crack that nurturance. So nurturance does require inner resources and helping to support the mom build that inner strength and feel good about herself as a person and as a mother. Relationships create relationships. It's not just that relationships evolve. And for some, in order to promote this emotional availability, much more than a little bit of help and support is required. We need to consider whether the caregiver may need to be referred for mental health treatment. We in early childhood in the mental health arena like to see referrals for dyadic work. So we want to see a referral for mental health treatment that involves both the mom and the baby. It's not just about referring the mom for adult treatment services. It does relate to her parenting ability. Now, how do these early relationships affect development? We know that the exploration that babies and toddlers do is affected by their attachment pattern. So babies who are securely attached can venture out a bit from their moms. They crawl around the room a little bit and explore toys, and they look back at their mom and check in. They make sure she's there. They might go over and tap her and then go back to play. But they're exploring their world really differently than most babies who have insecure attachments that cling and hold on to the mom's leg and do not leave her side to play. We see exploration of the world that is impacted by attachment. Also, we know self-regulation skills build from dyadic relations. So the mom's regulation and the dyadic regulation that she provides helps promote self-regulation in the young child. We know engagement with others may be modeled and affected by attachment style. So young children learn about engaging with other kids their age, even when they are toddlers. They learn from what they see in their world, and they experience the world in what's promoted as their ability to develop relationships. We all know that language and communication development is heavily influenced by relationships. We know language develops because of being read to, talked to, sung to, engaged with. And so relationships heavily influence this very, very crucial area of development for school success, school readiness, and later success in life. Cognitive mastery affects the child's social interactions with the wider world. The ability to master the environment is impacted by reciprocity, by the social interaction. The trust that a caregiver develops with the interventionist builds their trust, oftentimes, with a larger community and with other professionals. So sometimes when we're working with moms in the home, particularly, it's the first relationship that the mother has had with a professional. And it may be rocky at times. They're testing us. They're really seeing if we're going to hang in there with them, or are we going to be like everyone else and just walk away? This could be one more failed relationship, so they don't invest. But sometimes relationships take a longer time to build, but then we see these ripple effects that exist, and they're really good but hard to measure. We know they exist, and they may vary from family to family based on the personal histories and the experiences of the family members. The focus of our relationship-based work, and most of the work that we do in early childhood and family work, is relationship-based because we know how important relationships are. It's looking at changing attachment style for the positive, not the negative, and focusing on consistency and responsiveness in the caregivers. It's about improving that emotional availability and helping support it. It's about enhancing things like structures and routines in young children's lives, which again promote relationships, promote confidence, promote the sense of self, and promote school readiness. We look at relationship-based work as really important. It's needed to improve development, building on relationships all the way through, parents to professionals, parents to their child, the child to their peers. And it's the notion of reliability of the world. How can we support the caregiver in meeting these kinds of needs? What can we do if we're home visitors or early childhood workers or early Head Start workers? How can we support caregivers to meet their baby's needs? We know that the role that we play includes supporting and nurturing and containing family order. By containing family order, I mean the notion of holding the family and helping support them through these rocky periods and helping them learn to buffer. Sometimes we contain anxieties that they have about their child, about development, about their role as moms. It's this whole notion of containing that we do when we're working with families. It's about support and development and even the health of the infant caregiver relationship. It's about learning how to recognize areas of vulnerability and also those of resilience. Because if you just focus on the negative and the vulnerable side, we'd all give up this work. We wouldn't think about resilience and how we can build interventions based on the factors in that particular family that are positive, that we can work from, and that will help promote and help reduce vulnerabilities in that family, in that young child's interactions. So we need to consider what would help families access other resources that are needed to support the infant and the caregiver and that extended family. That includes concrete resources like food and housing, as well as services like developmental services or Part C services for their child. So we're helping families negotiate and access the services and the resources they need. Oftentimes, we're modeling and coaching how to initially access the services and resources so they learn how to do it on their own. What can the home visitor do in terms of development? Well, in supporting mom, just listening makes a big difference. We're going to be talking more about how listening to a mother's story is so important because it validates her world and her experiences. And reflecting on how that mother's early experiences may have shaped her ideas of herself and the relationship she holds, and how that may account for how she's behaving in the present moment. So this is something really important to talk about during reflective supervision sessions. This is something that we talk about with our supervisors to understand and to process what we're experiencing working with this family, and the frustrations that we feel when a mom is rejecting us and not answering the door, or setting up an appointment and then failing to attend the appointment. because it may relate to her early experiences and her own sense of self. And the reflective supervision sessions will assist with understanding and reflecting on those. We also provide what's called corrective emotional experience. We're helping the mother in new relationships, providing an opportunity to connect the past with the present and understanding that relationships can and should be different. How can we help to build resilience? We guide mothers. Babies need a lot of breaks from interaction. For example, thinking about that really small preemie baby who has neurological issues, who can only attend and interact for brief moments, then needs to look away and needs some downtime. So we help mothers understand it's not about them. It's not because you're not doing it right. It's not about your mothering. It's about what the baby just needs right now. They need a quieter, calmer environment, and they may need to turn down the lights if we're going to have happy engagement. The baby may need a little bit more quiet time in order to support their regulation. So help guide mothers with the baby. Help support mothers whose babies are fussy and irritable and indicating a lot of neurologic type of dysfunction and distress. And then again, linking families to those resources that they may need, whether they are concrete resources or emotional resources. When we think about the range of mental health services, we are all promoting infant and early childhood mental health by maximizing resilience. Think about things like provision of emotional support to families in crisis. We're thinking about helping the family to understand the child's needs and their care requirements when they have special health care needs. Prevention services are typically aimed at reducing risk. So what are some risk factors and how do we reduce them? How do we do preventive work in order to keep babies from needing treatment services? Think about things like family support and parent education. These can be promotion. They can also be early intervention, which is often designed for preventive services. The piece we leave with families about what to expect in the next few months of development, that information is overall aimed at prevention. We offer guidance. It's a strategy used in both promotion and prevention, but used commonly in prevention programs. Another aspect is the mentoring of caregivers. We do this by sharing what we're thinking about and what's going on. This way, we are mentoring and promoting it for caregivers to be aware if issues come up. With early intervention services, we are aiming at the earliest point pre-diagnosis. Early intervention services are about what's happening in order to prevent the need for intensive treatment services. And then you have treatment services that are aimed at conditions that are generally considered more severe. You look at treatment through departments of mental health or behavioral health services. There typically needs to be a diagnosis. There needs to be a diagnosable condition with medical necessity and standards for insurance and Medi-Cal for treatment services. There are a wide range of approaches to therapy. It could be a therapeutic nursery, for example. There's a wide range of approaches in terms of treatment for infant mental health, and we really want to see things like play therapy, behavior management, and regulation. Sometimes families are helped through treatment. A chaotic environment can be what's contributing to all of the dyadic problems, all of the dysfunction, and the acting out behavior in the young toddler. So we're looking at those kinds of issues. We also want to think about advocacy on behalf of the child and family and helping to build more resilience as appropriate to all levels of early childhood mental health services. Promotion is going to include all of these kind of things, including listening to mom's stories and thinking about what the mom needs to get off her chest or needs to talk about and just being there as a listening ear, helping to strengthen that family environment. So helping families understand the importance of routine. Some caregivers may not know that kids do better if they eat at the same time every day. They may have never had meals at the same time every day when they were growing up. Kids learn to predict and organize through structure, routines, and rituals. And so ordering the day is an important promotion strategy. Important kinds of prevention and early intervention strategies that we see include working with new moms who have postpartum depression and working with mothers who have other kinds of mental health diagnoses, such as moms who have schizophrenia or bipolar disorder. Sometimes when families come into treatment services, they may also have new home visiting services and goals in their childcare setting. We know that the family has mental health issues, so we want to help support and work with them at the earliest possible points and in collaboration with the other professionals they are working with. The intervention services, again, are looking at developmental guidance and strategies that overlap between prevention and early intervention. One example of a prevention or early intervention strategy are the purple crying materials that are often given out at hospital discharge about the peak period of crying in young babies and what to expect. And look at the steps toward effective, enjoyable parenting, or STEEP, or the Seeing is Believing approach, which is a spin-off of STEEP, developed by Brian Egeland and Marta Erickson of the University of Minnesota, and is used as a mental health guidance strategy and is a strategy for prevention. And then there are things like family support groups, Part C services, CCS kinds of services for physical delays or neurologic issues. There are also occupational therapy and support for regulatory issues and feeding evaluations and a range of things. And then another prevention approach that is really important to consider is for fussy and irritable babies. And it's a really promising approach that has been developed out of the Erickson Institute in Chicago. We are really fortunate to have with us Dr. Mary Claire Heffron from Oakland Children's Hospital, who is going to be showing a video clip and then talking a bit about the fussy baby approach that they've instituted and healthy baby work they're doing at the Children's Hospital in Oakland. So Mary Claire, welcome, and thank you so much for being with us. Dr. Mary Claire Heffron continued the webinar. Thank you, and thank you for setting the stage. This was a wonderful overview and a lot of information, but it was terrific. I'd like to start by setting the stage for the video, which is in Spanish. I will be the interpreter to give you a sense of a fussy baby intervention. Karen has given you this wonderful overview, and the Fussy Baby Program is an example of the kind of service that is seeking to enter early into the lives of families and babies to promote healthy relationships, to identify early on developmental or medical problems that families are struggling with, and very importantly, to promote healthy relationships. Our program got interested in the Fussy Baby approach because while we were running a very successful infant mental health treatment program, we were finding that no infants came. And the children that were referred to us were 18 months old, 2 years old, 3 years old, and all very needy of services. But we as a program with a long history of doing early intervention were in need of help to identify needs earlier so we could do more preventive work, prevent suffering, catch problems early on, and provide families with support. So we linked up with the Erickson Institute. What you're about to see is a very typical home visit. This family very generously allowed us to use the video. This baby is a recent immigrant from Central America, and the family is stable. What you're about to see is a family that has developed quite successfully, but with a lot of struggle. They have a business where they clean restaurants at night. And when this baby was born, there was a big change in the family pattern. Mother and father had been spending a lot of time together, and they had very little support in the community, which sort of heightened the mother's isolation. She was no longer able to work with her partner at night and was at home with the baby. Like 1 in 5 babies that are born are ones that we call a fussy baby and have a lot of native reactivity. This baby had a difficult time falling asleep and also didn't like things like having diapers changed, clothes put on and taken off, and most of all, really hated taking a bath. So what you're about to see for just a minute is an example of a typical fussy baby intervention with our home visitor, an early interventionist with mental health training, who works in a multidisciplinary team. You'll see her with the mother talking about the type of activity that they're going to do together, which is have a bath. We'll take a quick look at this video and then we'll be talking about it throughout the rest of the presentation.
Bueno, no fuera evidente lo que pasó para ella durante sus baños, si fuera de vestirla que no le gustó, o si fuera el agua, o si fuera...
El agua.
Usted piensa
sí,
ya.
nomás toca el agua y empieza a llorar.
Y ya, se asusta.
Sí,
¿Ves?
tiene que ser.
Oh, uy. un sonrisa muy pequeña para mí. Una sonrisa muy pequeña. Entonces, ¿usted piensa que es una buena hora para tratar de bañarla? ¿O porque
Yo digo
no,
que sí para que se duerme.
para que se duerme? ¿Porque se cansaría?
Sí, pues ya viene cansada de ella, del grupo. Pero
Ya.
sí.
Dígame un poco cómo reacciona ella durante el grupo. ¿Le gusta?
Como que se asusta cuando los otros niños lloran, cuando los otros bebés lloran, ella también llora.
Oh my goodness.
She's asking questions. We begin with collaborative exploration, encouraging the mother to talk about what it's like to give the baby a bath. This is part of what we call collaboration or co-creation of intervention. The interventionist isn't coming in telling the mother what to do. She's listening and they're figuring it out together. So we notice here, this home visitor is speaking in a very respectful tone to the mother, listening to her perception of the problem, but she's also not forgetting the baby. She's engaging with the baby, and a very important element of this model is the home visitors noticing the baby, what the baby is like, what the baby's sensitivities might be, and also, most importantly, touching on what Dr. Finello referred to as angel moments when things are going well. If we would watch the rest of this video, you would see that there are angel moments that the home visitor really highlights and underscores. All of this is really aimed at helping develop the parent's sense of efficacy. I can figure out my baby. I think I can cope. I understand, and furthermore, I can make a difference for this particular baby. In the fussy baby model, we're thinking about the 3 important behaviors of crying, sleeping, and feeding. All of the babies that are referred to us, usually from physicians or from nurses through WIC clinics and other home visitors, they're coming in with these symptoms. And particularly, we look a lot at the symptom of crying because this is something that is developmentally normal. We know that it increases lung capacity. We know that it increases motor activity, regulates temperature. And it's kind of this umbilical cord where it triggers interaction with parents. So crying is a good thing. There is a crying curve that has been measured and looked at in many studies across cultures where we know that babies cry more at certain periods of their life. So this peaking at 4 to 6 weeks is developmentally expected. There is certainly variation, but it's expected. Somehow, parents aren't often told this. And even if you've been told this, it can be quite distressing. It's an important piece of information, this crying curve. And also, very importantly, at the peak of the crying curve and slightly after, you see a point in time when we have the highest incidence of abusive trauma, or what's called shaken baby syndrome. So our funding for this program is a combination of public funds and private funds that's particularly focused on reducing shaken baby syndrome or abusive head trauma. Because anybody who has worked in public health or in early intervention knows the results of shaken baby syndrome are often devastating and lifelong. So let's look at in general why we worry about fussy babies. So as I said, we certainly know about the risk of having shaken baby syndrome. We know that also for fussy babies, there are increased risks, particularly when the fussiness doesn't decrease, where there are child behavior, development, and medical problems. Sometimes that tiny little curve that drops off so nicely around 3 months just doesn't drop off, and the fussiness continues, and parents are trying to figure out what's causing it. Is this signaling something else? We know that sometimes we see this continued length when there's family stress, when there's maternal or paternal depression, when there's angry conflict. There are many possible causes for when we see fussiness that exceeds this normal curve, so we're particularly attentive to this. Other things that we worry about are criticism and social isolation. The baby and mother in the video were very isolated in terms of relatives, friends, or a social network. The presence of a home visitor is a kind of witness or support to the mothers figuring out the baby. This is a tremendous protection for the family. Some mothers may have family members present. We see this a lot with teen mothers in particular. But family members aren't always so supportive, and people give a lot of advice to new parents. Some advice makes the parents feel less able. They feel criticized, and then they begin to feel that they're a failure. The particular approach of the Fussy Baby program and many home visiting programs is an open, non-judgmental approach designed to build and foster care and confidence in themselves, and really their ability to think about their baby, to attend to their baby, and to pay attention and analyze their own importance. Maternal depression is an enormous risk factor for the baby's development and also for the mother's satisfaction of being a mother. So often, our Fussy Baby interventions are discovering that when we measure maternal depression, assess at the beginning and again at the end, we often find that these interventions have been instrumental in reducing or eliminating maternal depression as reported by the mother. When a new baby is born, there is a tremendous role adjustment in families, particularly for a first baby. So we're working with the mother around the mother and baby relationship, but we're also trying to support the father to seek ways to be involved, to be supportive. We frequently enter into situations where there is some conflict, some feeling of being left out of the whole scheme of things. And so this approach also requires the home visitors to have a significant understanding of role adjustment when babies are born and how you include other family members. Some of the things we see and address early on involve going in and looking at times of sleeping and feeding. In the process, we may learn about the family's past exposure to trauma or grief and loss. We discover that there are relationship problems that are developing that may be related to things that have happened before the baby was born, as well as things that are currently happening. So we are standing ready with the Fussy Baby intervention and sometimes turn that into a longer term of intervention. Also standing ready as we see worries about housing, about jobs, and other family support issues to bring in a family partner who is able to give more concrete support with those kinds of social needs. Normally at this point, although not to scare you now, we would give you a loud sound of a wailing baby, but just kind of to look back in your memories to find that. Let's look at the next slide, which is risks to behavior and development. This has been an important part of the Fussy Baby program, identifying and working with families, pediatricians, and other specialists to figure out when sleeping and eating problems are persisting, and to figure out if there are other developmental or medical problems that are factoring into this. An example of this is a baby who had been weaned 5 months ago, refusing to drink fluids when his mom went back to work. He stopped drinking fluids, would only eat a certain kind of baby food, and seemed to need an OT evaluation. So we did some screening with the pediatrician who had not been concerned about this as much as the family had been. We went together with the family to identify if he could do a little bit of extra developmental screening and then get the baby into some occupational therapy to address these relatively serious feeding problems. Along the way, we were also working with some of the baby's other sensory processing needs that were making it difficult for the parents to get a sleep pattern established, and also making it more difficult for the baby to do some of the wonderful playing that we saw when we were with the parent. So the research on this is quite interesting. We're seeing again that crying past 5 months is linked to many problematic areas: motor, language, cognitive delays, behavioral problems and temper tantrums, negative reactivity, ongoing fussiness at 2.5 and 3, sleep disorders, feeding problems, hyperactivity, and it has also been associated with problems going on into early childhood, like latency of feeding problems and ADHD. That's quite a list, and again, this has been shown across longitudinal settings, and particularly brings us back to this notion of multiple risk factors. So as we work with these babies that might be called colicky, we're simultaneously working on trying to figure out other interventions and to co-develop ways to address that relationship with the infant early on so it's not negatively impacted. Let's take you back to the mother who wasn't able to get her baby to drink. Her sense of failure was immense. In her family, her relatives were criticizing her and constantly comparing her baby, her fussy, I won't drink a thing out of my sippy cup, and I don't like to play too much, and I don't do really well at family parties, with another robust baby almost exactly the same age. So this was devastating for the mom, but the short course of occupational therapy with support from our home visitor really got the baby back on track. We also screen for underlying medical causes, and for this reason, we feel on our team it's been beneficial for us to have consultation and a medical person on board. We often are seeing problems of reflux, occasionally some allergies, and sometimes some other issues that are getting in the way. So what the Fussy Baby program does is help really from a dual perspective. We have help in the here and now with whatever it is that's the urgent concern, and the long term is keeping focus on parent confidence and on the parent view of their child and this emerging relationship. Many things are going on, and intervention is designed to build parents' confidence. So we essentially move through increasing confidence, strengthening relationships, and promoting healthy development. Here again are the goals we've been talking about: increasing confidence, strengthening relationships, and promoting healthy development. The next slide is what's called the FAN. It's an overview of the approach which has been used by programs in the Fussy Baby Network. This approach is also now being infused into other home visiting programs, including Healthy Families. It's also being used in some Head Start programs. We're looking at how programs are doing this, but if you look at the steps in this, it's important to realize that the steps are not always done sequentially. So I will go through this quickly. The first approach is always empathic inquiry, beginning with, what's it been like for you to be with Johnny this past week? All of this is review because it's recognition that the parent is and will be in their state of mind, which is incredibly important to this child and the child's relationship. As we move through the next one, which is really interesting, you could call it calming or self-regulation. Most interventionists, and I will say myself included, when confronted with a crying baby, often want to rush in and sit and give advice. There are a million things we've learned over the course of a career about people's self-regulation. What the home visitors are doing is slowing themselves down so that they're staying in touch with the parent, and they're not telling or advising because of the vulnerability of a parent in this early stage of their child's life. Too much information is often seen as judgment or criticism. In the video, the home visitor was asking the parent to talk about details around a particular struggle that the parent was having, in this case with bathing. And as the home visitor listens to the details, she is sort of internally sorting and sifting out what's going to help, and also considering, how can I say something that will support and build this parent's capacity? Or what little piece of information is going to help in this moment without overwhelming the parent? So thinking, what is essential to capacity building, which is really at the heart of the program? How can we help the parents feel that they can manage a sometimes cranky baby? We sometimes ask the parent, what do you want to remember from this visit? What will you remember from all the things that we talk about? I'll share an example of a recent home visit where the mother's cousin had been shot and injured quite severely during her pregnancy. She was in a lot of trauma around the birth and was quite shaken about her own capacity. In a very long home visit, about 2 to 2.5 hours, they're telling the story of how this terrible thing happened to her cousin during her pregnancy. She told that story about the baby, and when asked what she wanted to remember, it wasn't what's happening to her family, but that I'm a good mother. Her own confidence was, in a way, given back to her by somebody paying attention, and the home visitor noticing the way in which she had managed several little caregiving incidents during the home visit. I wanted to bring someone from our program along with us. This is a very successful graduate of our program, and this photo is from graduation. Typically, we do a short intervention. Often the average length of our service is about 7 visits. Some families go on to other services, sometimes they don't. This is a little baby whose mother presented with multiple risk factors. She talked about how she had had a loss before the baby was born. She was living by herself. She was living in a high-risk neighborhood. And during the course of maybe 7 or 8 visits, she told us her story. When she came to us, she was greatly impacted related to the loss she experienced related to her neighborhood. She was a frequent visitor to our emergency room at Children's Hospital. She had multiple visits, and indeed, this is where our referral had come from. She had anxiety, something bad was going to happen to the baby, the way it had happened to her family member. Yet here at 5 months, you see a robust, beautiful little boy, a calm mother who, with the help of our family partner, had been relocated to a safer neighborhood, and who told us at the last visit, "I think we're good now. There's more people out there that need your services. I will call if I need to." So we let her go into the world, a happy, healthy baby with a devoted mother. We knew that we did something to help her, and also that she knows about the hospital and our program, and that in our community there are places where she could come back if she wants additional support in her parenting. Dr. Finello then continued the webinar. Thank you very much. That was wonderful. We are going to just cover a few more things before we open up for questions and answers. We wanted to briefly mention that sometimes more intensive services may be needed. Some families are going to need more intensive services, maybe medication for schizophrenia, maybe intensive therapy. When the baby needs intensive services, the baby may need dyadic therapy within the current relationship. Your local Department of Mental Health or Behavior Services can refer you to a really good qualified infant and preschool mental health practitioner. And we have also included red flags to consider about social and emotional development. Again, you don't refer because of a single or 2 or 3 red flags. You look at a cluster of things that create a concern that you can't deal with in a preventive way. And when you think this family could benefit from more intensive treatment, then you make the referral. So here's a list of 9 things to look for as red flags, which could trigger considering a referral. We want to really think about the fact that relationships hold the potential to help people to grow and to change. And this is what all of our work is about, this change through the relationship. And so we're going to begin to answer some of the questions that have been submitted. Dr. Finello answered a question. This question was about expressive language and the number of words that a baby has at 18 months. That number begins to show tremendous change until 36 months, dependent on whether they're from a family with college-educated parents, or they're from a working-class family, or they're from a family who is basically receiving care and is living in poverty. So there's generally a difference in these families. We know what's often happening is that the educated parents are stimulating and providing a vocabulary-rich environment. They're talking a lot to their babies, they're encouraging language, they're speaking a lot, they're reading stories, and babies pick up that language. So what we're seeing is the language just takes off starting at 18 months, and there's an enormous change. Next, there is a question related to Fussy Baby. In what states is the Fussy Baby program operating? So Fussy Baby is operating in Illinois, which is the place where this model was developed. And there are a number of other sites, such as the Colorado Medical Center in Denver. There's a program at the University of New Mexico. There's a program in Boston. There are several programs in Florida and a few others. At last count, we're at about 18 programs that are using this model. There are some that are a little further along in their implementation. We're actually going into our 5th year in Oakland. We are one of the older programs that are doing this. There's also a new program in Seattle. Another question that came through was to clarify the crying curve and then the chances of delay. Crying was not one of the issues measured in the risk studies that have been done, but we know from a lot of work on crying around the world that with increased crying, you see an increase in maternal depression, for example. This is a factor that's part of the risk factors that are measured and then are attributed. If you have a really irritable baby whose family could not cope with the crying and irritability, you have greater potential risk. Another question is about the 4 to 6 weeks peak and if that would be delayed or different in premature babies. The peak is corrected just as you would correct the age in a premature baby. So it's a pretty reliable curve. Again, you see with premature babies that depending on how premature they are and other medical or developmental issues that they are coming with, they may have irritability because of neurological difference that they're bringing because of their prematurity. We see many babies like this in our program who may have been drug exposed, and so part of their irritability is related to early substance exposure. It's hard to measure that, but often the referral coming out of the hospital is connected to the earlier question about crying being a risk factor. So if we see babies crying a lot or a mother struggling with her own recovery, then this increases the worries that you have about baby. Another thing to consider is when you look at peak crying periods of 4 to 6 weeks, and the peak in postpartum depression is also 6 weeks. So combine those two. It's the period where hormonally you've delivered a baby, things are going to peak in terms of the mother's depression, and they've got an irritable crying baby who is screaming. And no one told them this was going to happen. It would really be optimal if we could get obstetricians involved in terms of that postpartum checkup at 6 weeks with the woman who's just delivered a baby to look at and talk about the crying and all of this sort of normal behavior. If it doesn't resolve, what to do. But unfortunately, things that need to happen don't always happen. Optimally, we'd like to see obstetricians involved in doing some of this, supporting some of this work with families. We've worked very closely with a number of pediatric practices. We do short trainings with the people that are seeing the babies coming in for their well baby checkups and trying to help them do two things. One is to normalize that crying is normal, but for this particular parent, it may have other meaning. So we're trying to help them see that and also help them to make referrals in a way where the parents don't feel criticized or that there is something wrong with them or their baby because they're asking for help and are frustrated. Virginia Reynolds wrapped up the webinar by saying, if you want more information or are looking for information about training, please contact me at the WestEd Center for Prevention and Early Intervention. For the next webinar on resilience, we have Dr. Marie Polson as the primary presenter. She is a professor of pediatrics at the University of Southern California. So I think that this will conclude this webinar, and thank you all very much for your time and attention. We look forward to you joining us for the next webinar on resilience. Thank you.